Hi everyone, I am Emad Magdy, lecturer of nephrology in the Internal Medicine Department, Mansoura University. My topic today will discuss a very important clinical presentation of the glomerular diseases of the kidney, which is the nephritic syndrome. As an introduction, we should know that the nephrotic syndrome can occur as a result of the defect or inflammatory changes at the level of renal endothelium, leading to disruption of this endothelium and passage of the content of the glomerular capillary, which is ARPCs and the inflammatory white blood cells to the urinary space and to the urine. And this be accompanied by a problem in the glomerular filtration and problem in the salt water retention and the hypertension. The main causes share the intraglomerular inflammation, and this inflammation can be mediated by antibodies, by inflammation in the blood vessels, by immune complexes, antigen antibody complexes, which recruit white blood cells and recruit complement, and immune complex disease. It seems that all these expressions are new and the complicated expressions. So we have to do this introduction, the next introduction, in a whiteboard form to be simple as much as we can. Let's hear to this simple presentation. If we are intending to know the pathophysiology of nephritic syndrome, we should return back to the structure of the glomerulus. We can see here the afferent arteriole, the efferent arteriole. Then those are the glomerular capillaries. So the blood come from the arterioles to the capillaries, and those capillaries are embedded in a mesangial matrix. This matrix contain mesangial cells. If we return back to the glomerular capillary itself, we will find that the glomerular capillary have two surfaces. This one is the surface of filtration. Here is the blood, and this is the glomerular capillary membrane, and this is the other space, the urinary space. So the blood filter will be filtered through this membrane from the lumen to the Bowman's space. Collection of the urine in the Bowman's space will come to the proximal convoluted tubule, then pass from nephron to outside. Okay, this is a very general look. Let's have such deeper look of this glomerular capillary membrane or filtration barrier. This is the transverse section of the glomerular capillary membrane, and this is one is a 3D representation. So if we suppose that the blood come from here, this lumen is the blood space, and this is the endothelial fenestration which filter blood through the its fenestry. This layer is the glomerular basement membrane, and this glomerular basement membrane is covered by the epithelial cells, which is called the podocytes and the food processes of this podocytes come over the basement membrane. So the filtration barrier now is composed of this layer of fenestrated endothelium and this blue layer of basement membrane and this food processes of podocytes or the epithelial layer. Okay, so if we enlarge this photo into this diagrammatic presentation, those are the podocytes or epithelial cells. Those are the endothelial fenestra. And this is the mesangium. This is the mesangium. All this is a mesangium. And those are the mesangial cells. We should solidify some knowledge here. The cells which face the blood is the endothelial cells. The cells which face the urine is the epithelial cells. So the urine is here. So outside the podocyte is the Bowman's space which collect the urine. Any outer surface mean Bowman's space or urinary space. So let's go to the difference in the glomerular disorders. If any structure of the glomerular capillary is affected, we can divide this into two known muscles. Number one, the nephrotic syndrome. And number two, the nephritic syndrome. Let's know the differences. Number one, the site of the problem or the site of affection. Here is the podocytes and food process. So in the nephrotic syndrome, the affected structure is the podocyte and the food process. So those are the affected structures. This will lead to escape of proteins from the filtrate to the urine. So the first character of the nephrotic syndrome is the proteinuria, the massive proteinuria. The escape of proteins from the blood to the urine will decrease the oncotic pressure inside the intravascular space, and this will lead to escape of fluid from the intravascular space to interstitial space, causing edema. One of the proteins which is lost in the small protein lost in the filtrate is the lipoproteins and antithrombin 3. So the patient will be presented with dyslipidemia, and coagulation problem, and increased incidence of thromboembolism. Okay, so this is a very simple demonstration of the problem of nephrotic syndrome. On the other side, the nephritic syndrome, the problem is starting from inside or from mesangium. What's the problem? The problem that there is an antibodies. Those antibodies may be just antibodies or complexed, يعني immune complexes or antibodies. Those immune complexes have the ability to recruit white blood cells, different types of white blood cells around this area, causing inflammation, and this inflammation will cause destruction and disruption of these endothelial fenestra. And so the blood will come out from the capillary space to outside. So this immune deposition can be in the mesangium, can be inside the cell, so the inflammation also can be in the mesangium or in the capillary space. All of these will lead to recruitment of white blood cells, activation of complement, and destruction of this endothelial fenestra, and this will lead to the following: escape of proteins and RBCs to the urinary space. So you will see white blood cell cast and RBCs cast in the urine. Why cast? The cast is a protein which passes through the tubules, so it will take the shape of tubules. So we can name it as white blood cell cast or RBCs cast. Okay, this inflammatory infiltrate and this disruption of endothelium will disable the filtration process, and this will be presented with deterioration of GFR, renal impairment, salt and water retention, so hypertension. So the defect here, as we see in the endothelial cells, this is a very small representation of the pathophysiology of nephritic syndrome versus the nephrotic syndrome. Then after this simple idea we should solidify the knowledge by some real pictures. I know that those pictures may seem complicated to you, but just to let you know how this disease or how this clinical presentation will be presented. What are the symptoms and the signs I will find in the patient, and I'd like you to extract those symptoms and signs from these pictures. So accordingly, if we revise the last summary, if we have inflammatory cells in the capillary space or in the mesangium, or this mesangium increase in size, or these inflammatory cells occlude the capillary space, so the filtration will decrease and the GFR will decrease. And if the endothelium is ruptured, the white blood cells or the inflammatory cells inside will come to urine, and the protein will come to urine, but in a less amount than the nephrotic syndrome. It's not like the same amount, and RBCs, fragmented RBCs, will come into urine. Those are the hallmarks of the clinical presentation. Let's see here. This is the same as we represent in the diagram. This is the normal glomerulus. This is the Bowman's capsule, and those white spaces are the glomerular capillaries. This is the urinary space, and this is those deep pinkish stain is the mesangium, and those nuclei are the mesangial cells. Let's see here. Is this like than this? No. We see here that this pinkish material is severely increased, and we cannot see any space like this space. We cannot see any open space. Those are the spaces of filtration. So suppose that this patient have multiple nuclei. Those multiple nuclei are inflammatory cells plus increased mesangial cells plus increased mesangial matrix. So I hardly see any open capillary space. So sure, this patient will be presented with decreased urine output, elevated kidney functions, and hypertension, and RBCs cause hematuria, and this is why we name this pattern as membranoproliferative. Membrano means that this pattern have a membrane thickening, glomeruloplasmic membrane thickening, and proliferative mean proliferation of the mesangial matrix and the proliferation of the inflammatory cells, and the increase the number of inflammatory cells inside the capillary space. A last thing I'd like to know the difference in the terminology. In some kidney slides, I will see that the nuclei is very numerous. It is not like this one, the normal one. I here just see those few nuclei, but here the specimen is rich with many nuclei. If the proliferation of the mesangial matrix and the mesangial cells but no inflammatory cells, it is called proliferative lesion. But if there is multiple inflammatory cells inside the capillary, this is called exudative lesion. So exudative means there is an infection like the post-infectious glomerulitis, but this proliferative lesion. Why? Because here I see proliferation of the mesangial matrix, this pinkish material, and the proliferation of the cells normally present in the glomerulus, maybe the mesangial cells. But here there are some cells which is not normally present in the glomerulus. Those are the inflammatory cells. So this is an exudative hypercellularity, and this is a proliferative hypercellularity. Another type of hypercellularity is the crescentic glomerulonephritis. What's the meaning of crescentic glomerulonephritis? If you see here in the normal glomerulus, you will see just one layer of cells lining the Bowman's capsule. As a result of severe inflammation, it can be this line can be replicated multiple times. So to be more rows of cells, and sure, when the cells increase, will compress the tuft again, and will compress the glomerular capillaries again, and will lead to a presentation of severe form of nephritic syndrome, which is called rapidly progressive glomerulonephritis. What's the meaning of rapidly progressive glomerulonephritis? It's a clinical presentation, is a severe form of nephritic syndrome because most of the glomeruli are occluded at once due to compression by the proliferating Bowman's capsule. forming this shape of like the crescent, so we name it crescentic glomerulonephritis. Crescentic glomerulonephritis is a pathological term. The clinical presentation of crescentic glomerulonephritis is the rapid progressive glomerulonephritis. Why? Because this proliferation compress the tuft and occlude most of the tuft capillaries and lead to severe form of nephritic syndrome and the rapid deterioration of the kidney functions within days or few weeks. Okay? Okay, so if I asked you now, what are the clinical manifestations of nephritic syndrome? Sure, you will, if you get the idea from the previous slides, it will be very easy to you. So nephritic syndrome is a constellation of glomerulohematuria, proteinuria, but typically in subnephrotic range, rise in serum creatinine, and systemic hypertension. So glomerulohematuria and the biuria, why? Because I know that there is a disruption of the endothelium, so the RBCs will be fragmented and will skip urine. The white blood cells, which cause the inflammation or which recruited from the immune complexes or the antibodies, will be that. And here is one of the most common questions. What are the criteria of glomerular affection or glomerular hematuria? So the presence of dysmorphic RBCs or red cell cast are indicative of glomerular hematuria and is a hallmark of the nephrotic syndrome. Hematuria may be microscopic, but it is often macroscopic and the patient complain of dark or smoky urine. Okay, I think this is very simple now. Proteinuria is typically present in subnephrotic range. Renal dysfunction, we all know now. Hypertension and edema, I think I don't have to repeat this. It's quite clear now. The degrees. What the chronicity and the terminology. Basically, the nephrotic syndrome is an acute condition. As I see to you, it is a state of acute inflammation due to immune complex or due to antibody or due to vasculitis, and this all lead to recruitment of white blood cells inside the glomerulus, causing inflammation and necrotizing inflammation and necrosis, an acute problem. If it is progressed to more severe form with crescent formation, this inflammation stimulate the lining of the Bowman's capsule to multiply to multiple cells and compress the tuft completely or near completely, it will give a more aggressive form, which is a rapid progressive glomerulonephritis and associated with crescent and the renal biopsy. Some nephritic syndromes can persist over months to years with no change in the renal function, and thus referred to the chronic glomerulonephritis. So maybe the majority is acute. We have some extra acute or rapid progressive glomerulonephritis and some less chronic glomerulonephritis. So what can cause this? We have three main causes, and those main causes are divided according to the utility of investigation. How? We have immune complex disease. It means that the primary trigger is the formation of immune complexes inside the kidney structure, like inside the capillary lumina or inside the mesangium. Another form called pauci-immune. Pauci-immune disease means there is no immune complex, okay, but there is an inflammation, but not a simple inflammation. It's a type of necrotizing inflammation of the capillary lumina. It's named vasculitis. Other third form is the anti-glomerular basement membrane associated disease. There is an antibody. This antibody can know the glomerular basement membrane as a foreign body and react to it, causing destruction of the basement membrane. And this GBM or glomerular basement membrane antibody can take some similarity between the pulmonary alveoli and the renal vasculature and can make pulmonary and renal affection. So immune complex diseases, post-immune diseases, and anti-glomerular basement membrane associated disease. Inside the immune complex disease, it may be a systemic disease or renal limited disease. Systemic disease means that there is an universal immune complex deposition to any cause all over the body, and those immune complexes can be found in the kidney and outside the kidney. And the others, which is called renal causes, and those renal causes may be primary or secondary. So maybe an just immune complex deposition in the kidney only without other system affection, and we don't know the cause of this immune complex deposition. Those systemic diseases are numerous. The commonest or the most common causes of it are the post-infectious glomerulonephritis, the systemic lupus erythematosus, the subacute bacterial endocarditis, the hepatitis C induced immune complex deposition, and the IgA nephropathy or Berger's disease. You will take all of them separately, but يعني at a random idea about each one of them, you can read those small sentences. The post-infectious glomerulonephritis may follow streptococcal infection. Nephritis usually occur 1 to 2 weeks after the pharyngeal or cutaneous affection. The systemic lupus, we all take the systemic lupus. It's a complement levels are decreased because this immune complex will recruit white blood cells and will activate the complement system. So the complement will be consumed inside this inflamed area. So if I measure the complement in the plasma, I will find it low. This is very important term. Why? Because all the immune complex causes, I will find a decreased complement in plasma. And in the post-immune, there is no, the second category, the post-immune, and there is no immune complex formation, so no complement consumption. So if I measure the complement, it will be normal. So a normal complement nephrotic syndrome and hypocomplement nephrotic syndrome. This is why I told you that they put the classification based on the investigations I can do to discriminate between the causes. So if I have a patient with nephrotic syndrome, it means that the patient have hypertension, renal impairment, RBCs in urine, or RBCs cast dysmorphic RBCs. So I will test the complement and know, is it hypocomplementemic? If it's hypocomplementemic, it will be one of the immune complex disease. If it is normal complementemic, it may be post-immune or anti-BM disease. IgA nephropathy, will take IgA nephropathy as a separate case in the PBL. Again, it's a form of antibody which cause immune complex inside the mesangium and cause mesangial proliferation, and this mesangial proliferation will end by end-stage renal disease after a long time of period, maybe 15 to 20 years. This is a very simple mnemonic to memorize the most common causes of systemic immune complex disease which can affect the kidney and cause nephritic syndrome. Those are SLE, subacute bacterial endocarditis, shunt nephritis, cryoglobulinemia in the setting of hepatitis C, post-infectious glomerulonephritis, and when I said before, membranoproliferative glomerulonephritis. Again and again, what's the difference between those and the MPGN? The MPGN, the proliferative lesion, mean that the proliferation in the matrix and the cells of the kidney, but those are maybe of other inflammatory cells or white blood cell infiltration to the kidney. The renal cause or the idiopathic membranoproliferative, because the membranoproliferative can be caused by an infection, can be caused by tumor, can be caused by viral infection, all these can be caused idiopathically, renal limited type of membranoproliferative glomerulonephritis. The autoimmune disease, again, the characteristic of the autoimmune disease, number one, 40%, it account for the 40% of the patients presented with rapid progressive glomerulonephritis. So if I have a patient with rapid progressive glomerulonephritis, 40%, I have a 40% possibility that this disease is not an immune complex mediated, it's a autoimmune disease. If I test the following, the complement, I will see the normal complement. And those are a very important group of vasculitis, inflammation or necrotizing inflammation of the small vessels, small vessel vasculitis syndrome, or again may affect the other systems. So I can found the granulomatosis cholangitis named Wagner or Churg-Strauss or microscopic polyangiitis. And here I will find a specific antibody positive in those patients named the anti-neutrophilic cytoplasmic antibody. I may have a form of those, not a systemic, in this autoimmune is only renal limited and called primary ANCA associated glomerulonephritis. Here primary and secondary, primary here in the kidney mean the primary means affection of the kidney only. Secondary means that there is a universal body affection and affect the kidney secondary. The last category is the anti-glomerular basement membrane associated disease, and this account for the 10 or 15% of cases of rapid progressive glomerulonephritis. Again, it can be systemic disease, affect the lung and the kidney, cause pulmonary hemorrhage and acute glomerulonephritis, or renal limited associated with disease limited to the kidney best. So all the forms can be presented with systemic and renal limited. So we found in the immune complex can be systemic or renal limited. The autoimmune can be systemic pulmonary renal syndromes like the Wagner, Churg-Strauss, and granulomatous polyangiitis, and maybe renal limited. All of them are maybe systemic and maybe renal limit. If we try to solidify our understanding of all the previous slides, we can know that the steps of the patient diagnosis should be as follow. Number one, the urine analysis. Why? Because I will search for the which is called active urinary sediments. What are the active urinary sediments? The RBCs, the fragmented RBCs, the RBCs cast, the white blood cell cast, the proteinuria. All these are why they are named like this. It's an active inflammation products. So active urinary sediments may be first step of diagnosis. After this, I will do some serological tests. So to diagnose the immune complex diseases, I will do tests for those. Like what? Number one, the complement. It's expected that in the immune complex disease, the complement will be low. What are the causes? Systemic lupus. I can do ANA or anti-double-stranded DNA. Those are serological tests for diagnosis of lupus. I can do virology markers for hepatitis C. I can do cryoglobulins, which are the type of antibodies which can make complex in the hepatitis C. Those are the serological tests. So I have those which cover the immune complex. If I think about the autoimmune, I should test for the specific antibody for autoimmune, like the ANA and ANCA, anti-neutrophil cytoplasmic antibody. If I think about the anti-GBM, I can test the anti-glomerular basement membrane antibody. So in laboratory studies, as follow: the serum complement and the ANA anti-GBM antibody, ANCA, anti-streptolysin O, those are for the post-streptococcal glomerulonephritis. Hepatitis serology B or C, remember Sherg-Strauss syndrome is usually associated with eosinophilia. Then the renal biopsy. The renal biopsy is the gold standard technique for the diagnosis of any patient with nephrotic syndrome, and we should do renal biopsy for all the patients with uh, presented with nephrotic syndrome, but we should know that's an invasive maneuver, and the blood pressure of the patient should be controlled, and the uh, anticoagulation tests, complete blood count, normal platelet count, normal breathing time, normal clotting time, to not hazard my patient. But the renal biopsy will help me to see the changes I told you about in the photos, and will help me to differentiate between the immune complex disease and the post-immune disease. Because the immune complex disease, which I can see by the immunofluorescence, okay, will be positive in the immune complex disease. And post-immune means what? Means that there is no immune complexes that can be stained in the immunofluorescence stain. So the naming come from here. Post-immune mean there is no no detected immune complexes by the staining of the tissue. Immune complex mean that I found immune complex deposition by the immunofluorescence. The immunofluorescence technique in the pathology is very simple, that I put a fluorescent material that when bind the immune complex, or the immune complex can absorb it and give a light. So if there is immune complex, it will light. If there is no immune complex, it will not light. Overall treatment, this is a medical emergency. Why medical emergency? Because if I left the kidney without treatment of the cause, or specific treatment of the cause, I will lose this kidney. So any inflammatory renal disease should be treated with immune suppressive agents, which typically includes steroids or cytotoxic drug like cyclophosphamide or mTOR inhibitors or cyclosporins. Nephritic syndrome, due to preformed antibodies, may benefit from having those antibodies removed by plasmapheresis, especially in the setting of pulmonary hemorrhage. So it's a very easy and logic. If I know that the problem is antibody mediated, like the anti-GBM disease, if I clean this plasma from the antibodies, because all our antibodies are in the plasma. So if I exchange the plasma of the patient with new plasma, so I will decrease the antibody load. If the glomerulonephritis are secondary to any systemic disease, the primary disorder should be treated, like the Hep C, hepatitis C, or like the systemic lupus. Those are the treatments of the inflammation. I have a patient with a renal failure or massive form of renal failure. I should check some electrolytes and some acid-base disturbances. And if the patient is indicated in hemodialysis in the case of severe uremia or severe acidemia, or the patient is anuric or hyperkalemic patients, because hyperkalemic patients are prone to cardiac arrhythmia and sudden death. The patients with electrolyte disturbances should be corrected. The patients with volume overload should be corrected. Hypertension should be treated. Those are the general lines of treatment of nephrotic syndrome. But in each disease, you will take the specific therapy for the nephrotic syndrome. I know that you are new in the clinical phase, I'm happy to receive any question or any explanation, any point you don't get in the lecture, to my email, and I will reply it as soon as I can. At the end, thank you, wishing you all the good luck.